right, good morning. Oh boy, you had a great breakfast. We have a great day. The variety today is huge. Remember, this is the advanced study weekend. We need to go places where no one has gone before. Yeah, we do. We need to talk about all kinds of things in terms of medicine and nutrition. And as I have explained to you before, we don't bring people in who have the same opinions as Dr. McDougall. Why bother? And if I brought in people that said the same thing that I did, I'd do it myself because they couldn't do it as well. So anyway, there's different kinds of opinions, different people's opinions here, but they're all experts. They are people I have great respect for, or I wouldn't have asked them to take all the trouble to travel here and put together excellent presentations for you. So one thing you can assume, everybody that walks on this stage and speaks to you is somebody that I've wanted to hear talk, somebody I wanted to learn from, somebody I wanted to help you. This is not just about food. I've explained to you I've been at this for almost 40 years, and during my career I've written many books, and some have been about food, some have been about medicine. And the biggest critique I've gotten along the way is they've said to me, Dr. McDougall, why do you have to talk about bypass surgeons? You know, why are you picking on oncologists and diabetic doctors? Why don't you just stick to the food stuff? Leave the other part alone. Well, excuse me, I am a medical doctor. And my responsibility is to my patients. Yes, I'd like you to teach you to get healthy, well, by fixing the food. That's really important. But I also have a job as a general doctor, a job of protecting you from harmful tests and treatments that are delivered by my business. And that's what we're going to hear about this morning. We're going to try and put into perspective all of this aggressive treatment that everybody wants to get, all the testing that is necessary for you to have, and the treatments that follow up. Is this really a wise thing? Well, as your doctor, as your generalist, as somebody that you have hired to help you and your family have a better life, it's not just the food. I also have a responsibility to make sure you get proper medical care. And proper medical care, if I was to read this book, would be less medicine and more health. Less medicine, more health. Well, that's kind of counter to everything we've learned, but it's what I know to be true. And our next speaker has been a guest here on 3 occasions. I can't think of anybody who's been brought back here 3 times, so he must be pretty good. In fact, he's one of the most popular speakers we've had, and one of the people that I rely upon greatly when I make recommendations in terms of treatment and testing. It's a great honor for me, and I hope you also appreciate the willingness this man has to share, his honesty, to have Dr. H. Gilbert Welch come back to the Flamingo Resort and to talk to the McDougall people. And Gil, give it to him hard. Will you just tell him? Don't be easy on him. Tell him what you really think.
You want me to tell the truth, huh?
Just
okay.
They're good. They're tough.
All right. Good morning. Can I just say one thing? This is a really cool hotel. Did you guys like the Flamingo? I think it's a cool hotel. I was driving up, I don't know what, it's not 4th Street here, the one that comes right at the hotel with the mountain in the back. What is it? Arbors, yeah. And unbelievably, the Beach Boys were playing on the car radio. No, seriously. So I am really happy to do that. I'm talking to you twice today, that's overdosed, not overdiagnosed. That's overdosed. But I thought in the morning, this is an advanced study weekend. I thought we should do the heavy lifting. So this is a topic that is quite contentious, and I want to tell you at least where I'm coming from on screening, mammography, and overdiagnosis. I'll also say this is a talk I gave to the American Academy of Breast Surgeons. I gave it to the San Antonio Breast Conference. So I'm happy to say the breast cancer community is interested in these ideas. They certainly don't all agree with them, But there's actually a larger and larger fraction that does see the basic issues that I'm going to raise. And the way I want to sort of approach this is tell you how a primary care practitioner, that's what I am, thinks about breast cancer screening. And primary care practitioners, you know, we like to step back and get the big picture, get a sense of the whole, get a sense of the totality. And so I'm going to also say you might think of this as the view from space, right? It's stepping back and looking at the big picture. I'm going to start with my final slide. Sometimes it's good. I'll tell you where I'm going. I'm going to say something that's kind of radical. I'm going to say screening is a choice. It is not a public health imperative. And we've treated it as if it's a public health imperative. Instead, it's a choice. And in fact, it's a very close call. Let me start by saying breast cancer is an important disease. It is arguably the most important cancer for a non-smoking woman to worry about. If she smokes, she ought to worry more about lung cancer and heart disease. So, I'm going to keep a little list of things you should know. You might want to just write this down. The first thing you should know is breast cancer is an important disease. Now, I know you know that. I just want you to know I know that. Okay? I know that. All right, and now let's start with the good news. And there is good news out there. And the good news is about breast cancer mortality, the death rate from breast cancer. You're now looking at U.S. data from 1975 to 2010. Breast cancer mortality was stable till about 1990, and now it's undergone a steady decline. That is a 30% reduction. That is unambiguously good news. We should all feel good about that. That is the view from space. That's what I mean by stepping back and looking at the big picture. That's good news. So, now we're at the second, we're moving right along. We've got the second thing you should know. Breast cancer mortality has fallen by 30% over the last 20 years. Why has breast cancer mortality fallen? Well, now we're getting into a tougher area. There's more debate. But there are two conventional explanations out there. One, better treatment. Our treatment of breast cancer has improved. And second, earlier detection. Now, earlier detection, you can see screening mammography is underneath there. Earlier detection, though, of course, can happen more than just through screening. Women who feel a new breast lump may present earlier for evaluation. That's not to do with screening. That's about people with disease presenting earlier. But so those are the two basic categories of explanation for why breast cancer mortality has fallen. Better treatment and early detection. Now, I'm showing you a review in The Lancet by a group of doctors called the Early Breast Cancer Trialists Collaborative Group. This is one of the largest groups that keeps track of treatment data and summarizes all the randomized trials, and there are lots of randomized trials of breast cancer treatment, and asking about what is happening with breast cancer treatments. And they conclude that for women with ER-positive cancer, that's estrogen receptor-positive cancer, the randomized clinical trial suggests that new treatment developed in the 1980s and 1990s have resulted in a 50% decline in mortality. This is adjuvant chemotherapy and hormonal therapy. That's really good news. Now, you might say, well, gosh, why hasn't breast cancer mortality fallen more? The treatment's so much better, 50%. Why? That's a perfectly reasonable question to ask. And there's two explanations. One, effects seen in randomized clinical trials generally are diminished when they go into clinical practice. So what we see in a study doesn't necessarily directly translate to clinical practice. And the second, and some of you know this, is not all women have estrogen receptor positive cancer. A few have much worse disease. But this is the third thing you should know. Breast cancer treatment has improved a lot over the last 20 years. That's without a doubt. So that brings me to the debate about screening mammography. And let me be clear, there is no debate about diagnostic mammography. So let me make sure we understand the distinction between the two. A diagnostic mammogram is what happens when a woman notices a new breast lump, or a doctor notices a breast lump, and she has a mammogram to find out what that lump is. No one debates the value of that. Mammography is a good test to figure out what a new breast lump is. Screening is a whole different thing. Screening is about inviting the entire population of women to come in to see if we can't find something wrong. See if we can't find something wrong. That's where the debate is. Oh, I'm nervous about showing this at a McDougall. I eat Cheerios sometimes. Is Cheerios good?
It's on the program.
It's not a what?
It's on the program.
It's on the program. Okay. So and you might say, okay, why is this here? We're talking about screening, and a few years ago, I looked at my box of Cheerios and it had this on it, right, on your Cheerios box. I'm going, what is that? And I turned the box over, and this is actually what was there, and this picture was there. It's from the Susan C. Komen for the Cure, pinktogether.com. We're all in this together. Let me ask you, what is wrong with this picture? Any idea what's wrong with that picture? Look at those women. Well, there should be a man in there. Okay, well, I guess there could be. All right, I'll give you a hint. There's a woman with a diagnosis at age 25 there. There's a woman with a diagnosis at age 40. There's a woman with a diagnosis at age 33. There's a woman with a diagnosis at age 35. There's a woman with a diagnosis at age 23 on the back of a Cheerios box. Anybody see the problem now? The average age is 31. Any guess what the median age of diagnosis of breast cancer in this country is? Is it 31? No, it's 30 years older than that. It's 61. Now, this is part of what I see as a really disturbing feature that's literally scaring women about their future at a very young age. The desire to get people screened has led to some really unfortunate public messaging. This is less than 1% of all breast cancers. And it's on the back of a Cheerios box. I worry about it for my daughter. I mean, it's how do women see themselves, how dangerous they see their breasts as being. Now, October is Breast Cancer Awareness Month. Are you aware of that? Did you know that breast cancer awareness can get pretty crazy? Are you aware there's a breast cancer root beer? There's a breast cancer vacuum cleaner. I'm not making this up. They're breast cancer golf balls. Oh. Are you serious? A NASCAR? Oh! Any NFL fans here? You'll admit it? Me too. This is my New England Patriots playing Seattle Seahawks. Here's a Seahawks defender with pink shoes on. Here's another Seahawks defender with a pink, he's also got pink gloves. And then in the background here, there's the Seahawk mascot with two pink hands. And maybe you can't quite see the sign in the background. It's a crucial catch. Annual screening saves lives. Is that true? Is it the NFL? By the way, if you think this is just a New England Patriot fan talking about, here's, the Patriots are doing it too. Here they are. Here's our quarterback in pink shoes. What's that about? Wouldn't you imagine there might be more relevant health issues for the NFL to worry about? Do you think so? Head injury? Maybe. Domestic violence? Maybe. Firearms? Are there something the NFL ought to worry about a little bit more? Oh my gosh. Oh, and this is, okay, let's get out of the commercial world. This is the American Cancer Society in the mid-'80s. If you haven't had a mammogram, you need more than your breasts examined. Wow. You're crazy if you're not pursuing screening. That unbelievable messaging. So what is known about the benefit of screening mammography? Well, actually there are, depending how you count it, 8 or 9 randomized trials. And I'm putting them all up here for you, give you a quick sense of them. The first thing I want to point out is this number column, how many people, I'll sum it up for you. It's over 500,000 women worldwide have participated in randomized trials of breast cancer screening. And that's a tribute to them and a tribute to the people who are trying to figure out what's going on. That's a good thing. Now, there are all these randomized trials, but no one believes Edinburgh, that's in Scotland, not because it's from Scotland. No one believes it because, in fact, all-cause mortality in the Edinburgh trial was 30% lower in the screen group, from every reason. Well, that doesn't sound like a good randomization, and in fact, everyone understands it wasn't randomized at individuals, it was randomized by geography, and it led to very unbalanced groups. No one believes that. The HIP study up here, that's the Health Insurance Plan of New York, that's back in the 1960s. In fact, there's always been a question about their control group. Women were not consented to be in that study, and the control group never knew they were in the study. They were just coming off a list of the health insurance plan, and there's questions whether women with pre-existing breast cancer were actually in the control group. Swedish two-county trial, which is the trial the mammographers hold up as being such an important trial, has had numerous questions raised about the number of deaths not matching the county death records, and it actually involves only 45 geographic units being randomized as well. It's not at an individual randomization level. And if this is making your eyes glaze over, I just want to be clear. Randomized trials of screening are always messier than randomized trials of treatment. The reason? When you're doing a randomized trial of people with cancer, they're very connected to the healthcare system. You don't need a lot of them. 400, 300 patients, followed over 5 years. You can follow them. They're connected to the healthcare system. You can see what happens. Here you're talking about 50, 60,000 women who don't have cancer, who are healthy. Most of them are not very connected. You need to follow them for 10 years. It's hard to keep track of. They're always messy. Randomized trials of any preventive intervention in the well are very, very difficult to do. Back here, the treatment trials, there's no debate here. Everyone agrees in the community that treatment has gotten better. But there is a debate about screening, and part of it is because by its very nature, randomized trials of screening are messy. Anyway, the observed benefit in the randomized trial is somewhere between a 0 and 25% reduction in breast cancer mortality. No one thinks that screening stops all breast cancer deaths. No one thinks that. The observation is between nothing and 25%. Somehow, the conventional wisdom has become, though, that breast cancer screening reduces breast cancer mortality by 25%. Now, let's come back to the view from space. I'm going to let you look at this graph for a second and ask you this question. What do you make of this? Yeah, here are two countries that are next to each other, have the same genetic pool. The only thing that really differs between these two countries is the timing of the initiation of screening. One, Sweden, initiates screening about 10 years before Norway initiates screening. And yet the pattern of their mortality rates is virtually the same. And that's the first kind of big picture where people say, wow, is screening really that important? And Autier, that is a French physician who looked at this early versus late in countries that were otherwise similar. He compared Sweden versus Norway, Netherlands versus Belgium. Again, two contiguous countries. The only thing that differed is their timing of early initiation of population-based screening versus much later initiation. Northern Ireland versus the Republic of Ireland. That's the same island. It just happens to be very different healthcare systems. One is part of the UK, the other is the Irish. They had very different timing of the initiation of screening. He also looked at county-specific mortality patterns within Sweden, because Sweden started screening in different counties at different times. Gallagher looked at counties with and without screening in Norway. And McDougall looked at the effect of screening on ongoing mortality trends in England. And all these people are trying to estimate the benefit of screening in the era of improved treatment, because all the randomized trials are from 30 years ago. And these were trying to get a sense from space of what is the effect of screening now as it's being introduced in these European countries at very different times. And all these comparisons suggested that the addition of screening in this era had little, if any, role in the reduction of breast cancer mortality. Now, that doesn't surprise me that much. I would expect, as treatment gets more effective of clinically presenting breast cancer, that screening would be less effective. In other words, if we can treat clinically evident disease, the advantage of finding it earlier gets smaller. Why don't we screen for pneumonia? Because we can treat pneumonia. So here's the fourth thing you should know. Screening mammography now, and this is radical, but screening mammography actually appears to have little to do with the ongoing decline in breast cancer mortality. I'm not saying it has nothing to do with it, but it has little to do with it. And screening has real harms. Now that's kind of a new idea. Everyone thought, oh, early detection, it's all within your interest, there's no downside to it. But there are downsides. And the two I want to talk about are false positive results and overdiagnosis. And the first thing I want to do is be clear about the distinction. A false positive result is an abnormal mammogram, an abnormal screening mammogram, one that is read as worrisome, that then leads to some subsequent testing. Maybe it's just a second mammogram. Maybe it's an ultrasound. Maybe it's an MRI. Maybe it's some combination of all those things. Maybe it includes a biopsy. Maybe it includes more frequent mammography. But ultimately, the woman is told she does not have cancer. She may not be told she's normal. She may be told she has dysplasia, all sorts of, she may be at elevated risk, but she's not told she has cancer. But she's been worried by the process and feels less normal. Overdiagnosis is something different. Those are women who are told they have cancer, are treated for cancer, yet that cancer was not destined to ever cause them problems. So let's start with false positive results. This is 1,000 squares. This is the kind of thing I spend better part of half a day making. How's that look? It's pretty good. Okay. It's meant to represent 1,000 women screened annually over a decade. Now, even if this was an older population of women in their 60s and 70s, at most 12 would be destined to die from breast cancer in the next 10 years. And they're the only people you can help with screening. And this is a very important point about screening. Screening must involve many to potentially benefit a few. That's not saying that's not a reason to do it, but you just need to know the deal. You've got to involve a lot of people to potentially benefit a few. But screening can't help all those people. Even with the most optimistic estimates, it would help a quarter of them. So that's maybe 3. The rest are not helped by screening. And that's an important thing. Most people who are screened are not helped by screening, even with the most optimistic estimates about the benefits of screening. Most are not helped. And one of the questions I've been asking is, well, okay, what happens to the other 997 or 998, or I think it's much closer to 999.5? Well, in this country, in a 10-year course of screening, a lot of them have false positive results. This is the low estimate, 300. That is the low estimate of a false positive result. These data are from the mammographers themselves. These are not my data. These are from the Breast Cancer Surveillance Consortium. These are data that mammographers are collecting about false positive rates. And that's the low end. The high end is 700. Now, quite frankly, any organized healthcare system would look at this and say, this is outrageous. A population-based screening program that alarms over half the population ought to be abandoned. That's not good for your health. Now, it is reasonable, and there are value judgments here, to ask the question, how much does this harm matter? And I can't give you any definitive answer on it. That's ultimately a choice for each of us to think about. But this article came out that really caught my attention. I have not been one whose focus was on false positives. My focus has been on overdiagnosis, you'll see in a second. But I just want to share with you an article on the long-term psychosocial consequences of false positive screening mammography. And this was a study that followed women 3 years from their initial mammogram, and they're going to compare 3 groups of women. 174 women who had breast cancer diagnosed, 272 that had a false positive exam, and 800 who had normal exams. And they're going to measure 12 psychosocial outcomes at 5 points in time across 3 years. I'm going to show one of them to you now. This is the time. This is the point the mammogram is being done. Then they're going to repeat the measures at 1 month, 6 months, 18 months, and 36 months. I'm going to show you one outcome, it's anxiety level, and I'll put the normals up. Not surprisingly, the normals don't have much anxiety. Now I'll put the breast cancer patients up. Not surprisingly, they have quite high anxiety levels, and then they come down a little bit. So where are the false positive results? Well, they start here. And I thought, oh, that can't be right. That can't be right. A false positive has as much anxiety as a breast cancer? But no, this is when no one knows which group they're in. This is right after the mammogram. This is what happens right after an abnormal mammogram. The false positive doesn't know she doesn't have cancer yet. Now, 1 month later, it's down, right? Because now she's been told she does not have cancer. But 3 years later, her anxiety level is somewhere in between a breast cancer patient and a patient who has a normal mammogram. As I said, they did 12 psychosocial measures. These are the graphs. They all look roughly the same. I'll tell you what the measures were. The negative impact on sexuality, negative impact on behavior, negative impact on sleep, sense of dejection, need to take my mind off things, worries about breast cancer, loss of inner calm, felt less attractive. 3 years after a false positive mammogram, a woman's psychological health is somewhere in between women who have a normal mammogram and women who have breast cancer. Is this important? Well, I don't know. I think, maybe I'm old-fashioned, but I think health is more than a physical state of being. it's also a state of mind. And I think in medical care we have to be careful not to upset that state of mind, not to damage a person's sense of resilience, because I think that's a fundamental part of health. Overdiagnosis, that's the unfamiliar. Everyone's heard about false positives. And some people say, oh, false positives, they don't matter. I don't know, you make the decision whether they, I think they matter, but this is an interesting problem to me. The idea that we might be treating people who would never develop any signs or symptoms of their cancer. And you might say, how do we know that some people are being treated for a breast cancer that was never going to bother them? You know what this is? Oh, you guys are good. How do you know a black hole exists? Do you see a black hole? No. Well, first I should say, I'm not an astrophysicist. But I am told that physicists don't directly observe black holes. They infer their existence by what's going on around them. Lights being bent, their gravitational forces on other objects. It's an indirect observation, and that's very much the situation with overdiagnosis. We do not directly observe overdiagnosis, or we do so only rarely. The only way we directly observe it is when a diagnosed patient is never treated and goes on to die from something else, never experiencing symptoms of the disease. And there's some places where we have done that. Instead, we infer overdiagnosis from other data. And that's what I'm going to share with you now. The easiest to understand is a long-term follow-up of a randomized trial of screening. And I'll give you a sense of that here. This is one of the Swedish trials. It's done in Malmo. And this is its long-term follow-up from the Malmo randomized trial of screening mammography. 21,000 women in each group. One's being screened, the other's not. In the mammography group, at the end of the trial, there are 741 cancers found. In the control group, there are 591 cancers found. Now, I say long-term follow-up. After this trial's ended, they're going to wait another 15 years to see whether there are any cancers that catch up, whether the control group starts having extra cancers that were found early in the mammography group. And a few did catch up, 35. But that leaves 115 extra cancers found in the mammography group. Those are the overdiagnosed cancers. They never appeared in the control group despite 15 years of follow-up. Where did they come from? Well, they came from the screen-detected fraction. Even in a screening trial, about a third of cancers appear clinically. They're missed by screening. They just appear in between screenings. But here, about 475 were detected by screening. And the 115 come out of that 475. That says, of the 475 screen-detected cancers, 115, or 24%, of screen-detected cancers represent overdiagnosis. Imagine that as a headline. 1 in 4 cancers detected by mammogram would never pose a health risk. That would be an interesting headline. And for a number of reasons, I think Malmo's a low estimate. I'll tell you why. First, it was not annual screening. The more frequently we screen, the more likely overdiagnosis is. Malmo was done every 18 to 24 months. Second, the screening technology and practices changed. We're talking about a trial done in the 80s. Now our mammograms can see much smaller abnormalities. In Malmo, less than 10% of the cancers in the screening group were ductal carcinoma in situ. That's the earliest, smallest form of breast cancer. Now, in the United States practice, about 30% are ductal carcinoma in situ. And then we see stuff like this. This is just a few weeks ago. Molecular breast imaging nearly quadruples the detection of breast cancer. That's the direction we're going. We're looking for more and more, smaller and smaller. We don't need to find more breast cancer. We need to find the right ones if we're going to try to take this strategy. But don't think that the best test is the one that finds the most cancer. That's not right. So, my fifth point is screening mammography has a lot to do with women living in fear of breast cancer. the promotion of mammography, whether it's through the NFL or whether it's through Cheerios, all the false alarms, all the worrisome mammograms, all the biopsies, and so forth. And screening mammography has a lot to do with women being needlessly diagnosed and treated for breast cancer. So that's one way we look at how we know overdiagnosis is going on. Long-term follow-up of randomized trialist screening. Another way we do it is we look at incidence and mortality trends over time. And here, I'm not going to show you something about breast cancer because breast cancer mortality is falling and it's hard to know what's happening if we just look at incidence and mortality. But I want to show you another cancer because it's important for you. This is thyroid cancer. This is thyroid cancer in the United States, 1975-2010. Look how it shoots up. There's a threefold increase in thyroid cancer incidence. But what's happening to thyroid cancer mortality? It's totally flat. This doesn't look like an epidemic of disease. This looks like an epidemic of diagnosis. And pathologists have long known that although thyroid cancer was an extremely rare form of death, it's an extremely common finding at autopsy. And now we're beginning to unearth that reservoir of cancer, and we're treating these people. And we're not even the worst country at it. South Korea has experienced a 15-fold increase in its thyroid cancer incidence rate. It is now the most common cancer in South Korea, more common than colon, more common than lung, more common than breast. Its mortality rate's totally stable. Is that a problem? Yeah, that's a huge problem. That means a lot of people are having their thyroids taken out unnecessarily. Be careful with thyroid cancer. Okay, so back to breast cancer. The other way we infer the existence of overdiagnosis is by changes in stage-specific incidence following the introduction of screening. All right, this is the advanced study weekend, so we're going to see some advanced statistics here. First, I want you to understand how screening should relate to cancer stage. There are two prerequisites for screening to work to lower a cancer death rate. The first thing, it must advance the time of diagnosis of cancers destined to cause death. It can't just advance the time of any cancer diagnosis. It's got to find the cancers destined to cause death earlier in time. And second, early treatment of cancers destined to cause death must confer some advantage over late treatment. If late treatment's every bit as good as early treatment, screening won't help. So I want to focus on this first prerequisite. Screening must advance the time of diagnosis destined to cause death. It is insufficient simply to find more early stage disease. That doesn't mean screening's working. There must be a concomitant decline in those presenting at late stage disease. In other words, we need to take people who were going to present with late stage and move them to early stage. So here's a picture, and this is just an explanatory diagram of the expected impact on stage distribution of an effective screening program. If early stage starts here and late stage starts here, and you start screening, you expect to find more early stage. You expect that. But you also expect to find less late stage. It might be a little bit of the delay, but the whole point is you're moving people from this curve up to that curve, such that the overall amount of cancer doesn't change. Screening shouldn't cause cancer. Screening shouldn't cause cancer. You just want to shift people from the late stage to the early stage. So what's actually happened to breast cancer incidence in the United States? And this is a paper I did with an oncologist up in Oregon called The Effect of 3 Decades of Screening Mammography on Breast Cancer Incidence. It was the reason I was invited to talk to the breast cancer conference in San Antonio and the breast cancer surgeons in Las Vegas. And its original title was, in fact, The Effect of 3 Decades of Screening on the Stage-Specific Incidence of Breast Cancer in the United States. That was too many characters for the New England Journal, so they made us change it. But it is the view from space. It's saying what is happening over time to stage-specific incidence as mammography comes on in the United States. We're going to focus on women over age 40 because that's the group for whom mammography has been routinely recommended. We're looking at 1975 to 2008, and here I'm going to show you the incidence of early stage breast cancer diagnosis in the United States in women over age 40. As you can see, it's gone up dramatically. And now you want to know, well, what was mammography use? And I'll show you the National Health Interview Survey data. They first asked a question about use of mammography in the last 2 years in about 1985, when about 30% of American women reported having had a mammogram in the prior 2 years. It goes up to 50, 60, 70, and it smooths in around about 70% now. So this is the period that mammography is starting in the United States, starting around 1980. So the first finding here is that following the introduction of screening mammography in women age 40 and older, the number of women diagnosed with early stage breast cancer has roughly doubled. Good thing, bad thing? We'll have to see. So what's happening to late stage? Not much. And that's our second finding. There's been little compensatory decrease in the number of women with late-stage breast cancer. What we would have liked to see is this line going down, but instead it's relatively flat. So there's little compensatory decrease in the number of women presenting with late-stage breast cancer. Now, the first thing we said, well, is there some other reason for this? Maybe there's just more breast cancer in the population. And it's not perfect, but we said, okay, well, let's just look at the group not exposed to mammography and see what's happening to their breast cancer incidence. So we'll look at the women on the Cheerios box, the women under 40. So what's happening to early stage in women under 40? Well, it's flat. What's happening to their late stage? It's flat. So it doesn't look like something hugely has changed in the environment that's responsible for that huge increase in early stage. That's mammography. That's the effect of looking. In fact, the epidemiologists at the time said, yep, incidence is rising. That's the effect of mammography. So that's our third find. There's little change in the rate of breast cancer among women under age 40, suggesting there has not been some dramatic change in the underlying amount of breast cancer. Now, this imbalance suggests two things. One, screening mammography largely fails the first prerequisite for a successful screening program. It does not decrease the late-stage disease a lot. Maybe it does a little. We'll look at that in a second. Second, screening mammography is associated with a substantial amount of overdiagnosis. There's all these extra cases here with a very little deficit. That's a lot of people who look like they were never going to present with disease. After excluding the transient excess incidence associated with hormone replacement and correcting for the tiny increase in incidence observed in women under age 40, we estimated in this article that about over 1 million American women have been overdiagnosed since the 1980s. What are these new breast cancers? Well, obviously a lot of them are ductal carcinoma in situ. They are only found, or functionally, they're only found by screening mammography. And in fact, you can see that this is good evidence that there was no screening mammography down there because there's no DCIS. And then it shoots up. But it's not just DCIS. It's also localized invasive cancers. And that's our fourth finding. The overdiagnosis of early stage breast cancer is not simply DCIS. About half are localized invasive breast cancers. Now, I want to come back to the good news. The good news is that the breast cancer death rate is falling. But the good news is about treatment, not screening. Screening mammography has had little effect at the rate at which women are diagnosed with late-stage cancer. And that is the most important first step of screening, is to help people not present at a late stage. Now, what is that little effect? Let's look at this line. I'm going to change the axes so we can see it a little bit better. So you can see it goes up and then down, and up and then down a little bit. And most of that is all about regional or so-called node-positive disease. Most of it is axillary node-positive disease, stage 2 or stage 3 disease. And many of these women now, with the newer treatments, can be treated successfully. Not all, but many can be. So that's where the changes have been. By the way, this is incidence-based mortality data from SEER, looking at the various stages, regional, local, and metastatic. And what you can see is it really is regional stage disease where the benefits of treatment have really changed. The incidence-based mortality from 1985 to 2010 has been cut in half almost. That's the good news about better treatment. So what's left? Well, what's left is metastatic breast cancer. This is the rate at which women present with metastatic breast cancer, and it hasn't changed. And this is the group that would really benefit from an advance in their time of diagnosis. This is the group we'd most like to move into an earlier stage, but we haven't seen that. And that's an important, and it's a sad thing. The rate at which women present with metastatic cancer, a stage that's extremely difficult to treat, sadly appears not to have been affected by screening. It's just a stable rate down there. We also made one other observation. The decline in death among women exposed to screening, age 40 and older, is about the same as the decline in women not exposed to screening. In numerical terms, it's actually a little higher in the younger age group. It's getting better faster in the under age 40. But this again suggests what we're seeing in mortality is about better treatment. Our treatments have gotten better. Now this is just from a few weeks ago. This is maybe just last week, March 3rd. What is it? That's last week. The mammography community has some leadership that is pretty feisty. And breast cancer not overdiagnosed by mammography. Now this is interesting. In the radiology community now, radiologists are totally aware of overdiagnosis of renal cell carcinoma, kidney. They're totally understanding of the thyroid cancer problem. They're actually rewriting guidelines on incidental thyroid nodule detection to try to avoid the overdiagnosis problem. The radiologists involved with lung cancer screening, they're totally all over overdiagnosed. The whole design of lung cancer screening is designed to not immediately biopsy small lesions, but wait for them to grow. They're trying to reduce the overdiagnosis problem. But the mammographers, they're radiologists too. It just doesn't happen. And instead they say this, the idea that breast cancer is overdiagnosed is being perpetuated in an effort to reduce access to breast cancer screening. It's like Dr. Nessel said last night. It's a little bit like the cigarette companies. It's attack that, attack anyone that's suggesting anything other. Just deny the existence of the problem. Overdiagnosis and overtreatment are used to create fear and confusion. However, mammography is not responsible for either one. And now I like this. Pathologists make breast cancer diagnoses and oncologists determine treatment. This is one of these, not my problem. I'm sorry, it is your problem. If you're in charge of the most prominent screening effort in the United States, you need to take responsibility for both overdiagnosis and false positive results and see if you can't make the problem better. You don't deny it and then point your fingers at your colleagues. Now there was some critique. There was quite a bit of critique of this article, and I'll put them into two categories: smoke screens and distractions and healthy scientific debate. The smoke screen is the SEER data are bad. That's the federal government's effort to collect cancer incidence and mortality data in the country. When I heard this, I just couldn't believe it. Okay, so our federal cancer statistics are no good, to which my response is, okay, well maybe the 30% mortality reduction is spurious too. I don't think so. we've been pretty good at counting cancer incidence and mortality data for years. Another critique is ductal carcinoma in situ shouldn't count. Excuse me? Tell that to the 62,000 women who were diagnosed and treated for it last year. I don't think so. It does count. We treat it like breast cancer. It starts a whole train of events. Now, the healthy scientific debate is how good is your estimate of underlying incidence? We're basically saying that without mammography, incidence would be pretty flat. And we support that by saying, look, in the under 40s, there's no change, essentially no change. And using the women under 40 to estimate incidence is certainly not perfect, but other data supports a stable disease burden, namely the flat rate of metastatic disease. The fact that metastatic disease is stable over these 30 years suggests to me that the amount of bad breast cancer is pretty much stable over time. Now, I want to show some new data. I'm going to end with some new data, and this is not published yet, but will be out in a couple of months. And I'll leave you with it so you can think a little bit more. It's another view from space, but now we're going to look at 547 counties that report to the SEER database. This is the federal government's major effort to track cancer incidence and mortality. And again, we'll focus on the population of women age 40 and older. And what I'm going to plot things against is against the county reported rate, and this is also data the federal government collects, of the proportion of women greater than age 40 who had a mammogram in the past 2 years. There's considerable variation among individual counties about how much mammography there is. And then I'll put rates on the y-axis. This is the relationship with incidence rate. This is incidence in the year 2000. And the circles, big circles are larger counties, small circles are smaller counties. And what you can see is counties with higher mammography penetration or extent of mammography have more breast cancer found. Doesn't surprise you, right? You look harder for breast cancer, you find more breast cancer. And for those of you who like correlation coefficients, it's highly correlated. Counties that screen more have more breast cancer, find more breast cancer. This is what the county mortality rates look like. These are the so-called incidence-based mortalities. This is the number of deaths in the next 10 years among these women up here diagnosed as the population. It's flat. In fact, for those of you who like correlation coefficients, it's not correlated. It's a zero. This looks to me like the prominent effect of mammography is overdiagnosis. That is the most obvious effect from what you see from space. More breast cancer diagnosed and treated. No effect on mortality rate. Let me just show you lung cancer for a second as a function of proportion current smoker. And what you see is an exposure associated with consequential disease. More exposure to smoking, more new cases, more mortality. Breast cancer, that's what you just looked at before. That is an exposure that is associated with overdiagnosis. More cancer, no change in mortality. We separated into small and large breast cancers, cancers smaller than 2 centimeters. That's where there's a strong relationship. What does mammography do? It finds small cancers. Does it find fewer large cancers? No, it's pretty flat across the counties. You'd like to see this one going down because you move people from this over to here. But instead it looks like you just find more small. You don't find less large. Here it is by stage. Early disease. This is so-called stage 0, 1, and 2. Locally advanced. This is bigger than 5 centimeters or multiple nodes or metastatic disease. It's totally flat. Again, if you see more of this, you'd like to see less of that, but you don't. You see just about the same amount. And what does this do to surgery rates? Well, it means there's a lot more breast-conserving surgery, but there's about the same amount of mastectomy. So one of the things that screening's often been promoted is as a way to reduce more aggressive treatment. Well, it looks like mastectomy is pretty flat across the counties. What it really does is add in more breast-conserving surgery. So the bottom line, these data raise serious questions about the value of screening mammography. They clarify that the mortality benefit is likely smaller and the harm of overdiagnosis is likely larger than has been previously recognized. While women should recognize that this work does not answer the question, should I be screened for breast cancer, they can rest assured that the question has more than one right answer. This is not a single right answer question. Here is an article I published trying to take the most optimistic and pessimistic estimates to give you some sense of the trade-offs in mammography. Among 1,000 women age 50 undergoing annual mammography for 10 years, there are benefits and harms. The benefit is somewhere between 0.3 and 3.2 women will avoid a breast cancer death. The 3.2 is the most favorable finding of almost a 40% mortality reduction from one trial. My belief of the honest answer is it's much closer to the 0.3. But I'm just giving you a range so you have some sense of the uncertainty and the magnitude. The harms in this country. If you don't live in the United States, ignore this data. No other country has this. But in this country, of that 1,000, somewhere between 490 and 670 women will have at least one false alarm. 70 to 100 of them will undergo a biopsy. And then this is the unfamiliar part. Somewhere between 3 and 14, and I'm afraid the number's closer to the 14, women will be overdiagnosed, treated needlessly with surgery, radiation, and chemotherapy. By the way, even the cancer screening community in Britain, the UK, that runs their breast cancer screening program, now tells women in a booklet that their chance of being overdiagnosed is about 3 times as high as their chance of having the benefit of avoiding a breast cancer death. Now, I want to be clear, there is no right answer. There's no single right answer here. We can all look at these data a little differently. We all have different values we bring to it. But I do think we can agree there's not a single right answer. And that's why I say screening is a choice, not a public health imperative. Thank you very much, and I'll be happy to take your questions. A lot of data in the morning, wasn't it? A lot of too much data?
Not enough.
Too much data? Too many dots? Too many lines? Sorry. But this is the advanced study weekend, right?
No, it's good data, and as many of you have heard me say, Dr. Welch is one of the people whose shoulders I stand on because he does the basic research, and the subject of mammography is very sensitive. It's political, emotional. We're talking about women. You know, it goes far beyond what the science is. And so just one of the bottom line questions that every woman in this audience is asking is, they're asking 2 questions, Gil. One is, what does your wife do?
My wife's had breast cancer, and that is public knowledge, and she's doing fine, thank you very much. She had not a screen-detected lesion. She had a palpable lesion. And she's doing fine.
Well, I'm sorry, I didn't mean that as a personal question.
No, but I think you asked me this last time.
But what they're sitting thinking is your sister or your best friend or your wife.
Right.
What would you, I mean, if you just kind of sat down with a cup of coffee and nobody was listening, what would you tell them to do?
What am I going to tell my daughter?
Yeah, what are you going to tell her to do?
Yeah, I mean, she knows this whole story, and I'm going to say it's a choice, but
nah.
You know, it is a choice. No.
You're the expert, Gil. What are you going to tell her to do?
Yeah. Let me say one other thing. Are there other parents in this room? When you have a 26-year-old daughter, you don't tell her what to do,
No.
John.
Okay.
I mean, you don't tell her what to do, but she'll make her own choice, and We'll see.
I can't accept that. I just plain and simple cannot accept that, Gil. You and I are friends. You are the expert. You are the doctor.
I'm not. Yeah, but I'm not telling her what to do.
Patients, no. You are. Patients are looking to you as the expert. Me as the doctor. You don't know the data. What are you going to do?
I can tell you what I'd do if I was her.
Yeah, say you
I
have
wouldn't
breasts.
do it.
Okay, there. Yeah, thank you for the answer.
I wouldn't do it.
All right.
No, I think it's. I absolutely wouldn't do it.
Okay, so you wouldn't do it.
But that's my values. You know, I say I'm the first to acknowledge there are probably a few people that are helped, but so many more are harmed in the process. And of course, the whole question of whether it affects overall life expectancy is a whole nother thing I didn't even get into. I just value not being medicalized unnecessarily. That's a personal value, and we all have to make these value judgments. But I value not being medicalized unnecessarily. I want to be clear because now I feel like, oh, the anti-doctor. I go to the doctor if I'm hurt. I will. I have. I think docs can do a lot of good for people when they're sick, acutely injured. And so it's not like I'm afraid of doctors, but I know we can't offer that much to people who are well, and we can get them involved in a train of events that leads them to a place they do not want to be. So I'm a believer in medical care. I'm a believer in medical care for people who are acutely ill and acutely injured. But boy, when you're well, you got to be much more careful. It's a much closer balance. Let someone else ask a question.
No, one more question.
Should I let him?
We're going to get a whole hour of this.
No, all right, come bring on.
But I mean, if I, as a board-certified internist, as a medical doctor, look to you as the expert, I've heard your answer clearly.
Okay.
Okay. Now that I've heard your answer, for you personally, I know it's everybody's judgment, whatever, but you're the expert. Now that I heard your answer, you would not get a mammogram.
No.
How am I going to find my breast cancer then? If I'm not getting a mammogram, how am I going to find my breast cancer?
But that's one of the nice things about the breast, relative to the prostate, right?
Come on now, this is a clean audience.
No, it is. I mean, you see them every day. You're moving with them. We want women to be aware, not to do self-exams, but just to be aware. And you become aware of something new, an abnormality. By all means, no debate about going in to see what that lump is. That's a very different approach than looking hard, trying to figure out, and finding things that people can't feel. I mean, that's where mammography went so far wrong. Was with this desire to find the smaller and smaller and smaller and smaller. That's where we went wrong with screening.
I'll be back.
Yeah, I know you will. Whew. I got to sit down after that. Yes, sir.
Dr. Welch, thank you for the excellent talk.
Thank you.
I was wondering if you could talk a little bit about the idea of reclassifying DCIS.
Yeah, I think that's a great... so the question... when I was a fellow, a mentor asked me, do you want to study nosology? And I'm thinking like it's ENT or something like that. But no, it's all about classification of disease and the labels we put on it. I had no idea what it was about. Now I realize it's one of the most fundamental issues in medicine. What do we call things? This early lesion associated with microscopic calcifications in the breast was labeled ductal carcinoma in situ. I had the privilege of talking to one of the senior pathologists who was originally involved in that nomenclature in the 1970s, and he said something I'll never forget. I so wish we could do this again. I would have never put the word carcinoma in there. If I knew how that label was going to drive clinical therapy. He thought the in situ would make it clear. So I think it is, the question is, there's been an interest and a NCI working group on the whole question of nomenclature of early cancers or early abnormality. You know, what is cancer? You know, it becomes all this debate to use something like IDLE. I think that's probably a step in the right direction, although I think we all need to recognize that the cancer, and I'll talk a little bit about this in our second talk, is a much more heterogeneous group of diseases than we ever appreciated. And we need to appreciate that the minute you hear the word cancer, the right answer isn't always, do something fast. You need to step back and learn more. Sure. Thanks for that question. Another hard guy.
Yeah, I want to thank you for your presentation, and also I want to thank you for your book, Overdiagnosed. That book absolutely changed the way I look at patients, I look at what we do, I look at what my colleagues do, and I'll never be the same. So thank you for that.
Thank you.
But my question, my comment is, our mammography colleagues have now come up with new technology called 3D tomosynthesis, which seems to imply that this may be a technology that reduces false positives and needless biopsies, but the jury's still out on it. What are your thoughts about that?
Yeah, so this is basically a CAT scan of the breast, adding that third dimension. And there was a suggestion in what I would say was a terrible before-after study. It wasn't a randomized trial, of a slightly lower rate of false positives, which would be a good thing. I mean, that would be a good thing. I'm not sure whether in practice it will really produce anything like that. I think the way to reduce false positives is not to be looking so hard for really small things. We need to fundamentally adjust the threshold for what mammographers are looking for. It also was a technology that found more breast cancers, and this comes back to one of the most central things I'd like to leave this group with, is this is not the way to judge how good a test is, because it leads to a cycle of increasing intensity where the best test is always the one that finds the most cancer. And mammography has been finding more cancers as it gets more detailed, higher resolution. Now you're going to do a higher resolution, you're finding more breast cancers. Is that a good thing? You add ultrasound, you find more. You add MRI, you find more. And now with molecular breast imaging, you find 4 times as many. We've already got a problem with finding too many breast cancers. We need to be finding the right ones. So anytime you read in a newspaper a new test that finds more cancers, you ask, are they finding the cancers that matter? So I think it's a really fundamental, and it's a hard sell, because everyone says, well, of course, that's exactly what you want to do, is find the most cancers possible. But I'm here to tell you, it is not what you want to do.
Good morning.
Good morning.
I'm a retired diagnostic radiologist, and I have several things to share with you. One, I agree with the prior physician's testimony for your book. I give that book to any physician who will read it.
Oh, thank you.
And secondly, a couple of stories that you might enjoy about 2 other retired radiologists, one of whom was with me in residency, my best friend in residency, very compulsive man. And he was the lead mammographer in a medium-sized group in Connecticut. And he followed all his patients forever. He kept records on all the mammograms he did, and he followed them. And when he retired, I asked him about mammography. And he thought for a few minutes. He said, I don't think it does any good.
Yeah.
Now, that was the first anecdote that's sort of fun. The second is another retired radiologist, my best friend from medical school, who practiced in a very large group in South Florida. And we talk about medical issues. And I said to him, what's this thing with mammography? And he said, let me put this in perspective for you from other points of view. My group in Florida has 10 full-time mammographers. That's all they do. That was their subspecialty training, and most of them have been in it for a moderate amount of time. He said they don't know how to do anything else. They are out of work if screening mammography disappears. So you have a huge industry that, even if we go to Medicare for all, is going to fight tooth and nail for this procedure, because it's the only way they can make a living. And these are smart, articulate people who are committed to something that both you and I believe is a real problem.
Yeah, thank you for that. And you're absolutely right. The radiology is a heterogeneous, it's like cancer. Radiology is heterogeneous. The mammographers are an isolated group. They just do one thing. There are some that are really asking questions. I want to be clear. There's some younger ones that give me some hope. The old guard is very much entrenched. It is what they do, and it's ironic because their colleagues, as I say, really are sort of leading the way on the problem of overdiagnosis and thinking about it in lung cancer, in kidney, renal cell carcinoma, and in thyroid cancer, and it's a very tough economic self-interest hurdle for us to get beyond, and I don't have an easy solution to it. Yes, sir.
The slide you had about increased diagnosis and mortality staying the same, the mortality numbers were from breast cancer or from all causes?
No, I'm sorry. It was incidence-based mortality from breast cancer.
So that doesn't speak to the deaths that occur from complications of anesthesia, surgery, infection, and chemotherapy.
Yeah. You are correct. Well, it all depends on how deaths are coded. But you're right. And I've actually looked at this because I've been interested in, you're asking about treatment-related mortality. And my estimate on
diagnosis.
Diagnosis and treatment, yeah. And depending on, the diagnosis related would never get in. Some treatment would be included in cancer mortality. But your point is well taken. It's probably missing some of the adverse effects of extra treatment. Yes, you're
I'm an anesthetist, and I've worked in operating rooms for 40 years, and I can tell you that anesthesia and surgery is not without its risks.
Yeah, your point is very well taken.
My second question is, what are your observations about any changes being made, say, by governmental guidelines or recommendations to reduce the amount of mammography that is spun as a plot by the government to harm women?
Yeah, it is. It's a very lot of distractions out there. It is very hard to dial back, and that's why I think it's very hard to dial back when it's someone that could be perceived as taking something away. And that's why I think it's very important to share with women the two sides of the story and let them choose. Because I think anything else creates more it becomes a barrier to actually actual change. I think the real way to change is to tell women the truth and let them make their own decisions. I believe that's true for a lot of things in medicine. We should just be a little bit more open about the balance involved. And we shouldn't, and the public health community needs to get that. They need to focus on health promotion and not supporting various industries, yeah.
Hi, good morning.
Good morning.
Thanks for raising some really good questions. And, I think a lot of people in this room have been, had people close to them that have been touched by, breast cancer, and people that have been diagnosed early and done well, and people that have been diagnosed early and not done well.
Yeah.
And maybe the reclassification of DCIS will help some of that. But my question for you is, I'm curious how I haven't read your book yet, but curious how you might compare this breast cancer scenario to colon cancer and screening for colon cancer and polypectomy. And I sort of see the polyps, the early removal of polyps and rescreening more frequently, to the early removal of precancerous breast tumors. I'm curious what you would comment on that.
Well, first let me just respond to the fact that we all know people who had breast cancer, and a lot of people who were detected by screening who are doing great. And ironically, I just want to comment, because I didn't make this point, is ironically that becomes a really positive feedback for more screening. Is, of course, most people who are screen detected will do great, particularly those that were never destined to develop clinical disease. And this is yet one of the most misleading parts of the system is that every survivor is seen as someone who's benefited, and that feeds back to more intensive screening and looking harder. It's been called the popularity paradox. Ironically, the more overdiagnosis a test causes, the more popular the screening test becomes, because everyone sees all the survivors and say, geez, I want to be there too. The relationship to colorectal cancer screening is imperfect. Certainly colorectal cancer screening leads to a lot of downstream testing, a lot of repeat testing. The one thing it doesn't do is it doesn't seem to have this same overdiagnosis problem. We're not seeing colorectal cancer incidence skyrocketing. We're not seeing more surgery for colorectal cancer. In fact, we're seeing less. That's good. So it doesn't have the overdiagnosis. Why here we're seeing more interventions on the breast and more chemotherapy. The net effect of colon cancer screening is a subject of considerable interest. I can say my institution is running a large, and I told you these screening trials are messy, but we're running a trial of fecal occult blood testing versus colonoscopy, because everyone's always assumed colonoscopy would actually be an improvement, but that's actually not quite clear. So these questions are a little bit outstanding. But the one thing I could say about colorectal cancer screening, it doesn't seem to be associated with the same amount of overdiagnosis as breast cancer screening, or prostate cancer screening, or lung cancer screening for that.
Hi. As you were talking, I had a couple of thoughts. I actually have two questions. You didn't mention family history.
Yep.
And when you had the chart up there about the anxiety, I couldn't help but think that for people who have all the females in their family all dying of breast cancer, the anxiety is a constant, ongoing, maybe like an 8 or a 10. So that's always a free-floating constant. And so when I have screening, I come out of there with zero anxiety, where previously, because of all the family members, prior it was much, much higher. But also, as far as the invasive after treatment, after, in overdiagnosis, for example, let's just take a biopsy. That seems so insignificant and simple that I always say, who cares? It's about, it takes less time than getting your hair cut.
Right. So
am I oversimplifying it?
No. You're telling me let me separate the two parts of your question. Let me start with the second part, which is the question of, how much does a false positive matter? What's a biopsy matter? And you're telling me your own values, and that's perfectly fine. That's great. That's why I say people have to make their own. Is this a headache? Is it terribly scary, or is this nothing? And if it's nothing, take the false positives off. They're really frequent, then it's not part of the equation. It's just about overdiagnosis and whether to me, the central question is how well does mammography even work? So you're absolutely right. Whatever you feel about the false positives is right. I shouldn't tell you how you should feel about that, because I think everyone feels differently, and that's okay. As to your first question, that's a really important question, and I'm so glad you asked it. And I've always said the people that stand to benefit the most from early detection are the people at the highest risk for the disease. So women who have the genetic abnormality or mutation of BRCA1 or BRCA2, they're not at 50% higher or 70% higher or 20% higher. They're sixfold. They're at a sixfold increase for breast cancer, and they're tenfold for ovarian cancer. That's probably one of the most important pieces of genetic information we have for these diseases, and that's a group that stands to benefit the most from screening and, ironically, has the lowest chance of being overdiagnosed. They're more likely to have a real cancer. So a lot of people who, as they think about screening, they're thinking about risk-based screening, and that's exactly, I think, what you're talking about. Thank you.
Dr. Welch, my name is Evan Allen. I'm a family physician in Henderson, so I'm seeing the primary care view from space, sort of like you do. And I want to thank you for your talk today and also for your book, Overdiagnosis, which also, for me, was a revelatory experience and was great. But I do have a real question for you, which is that screening mammography has become literally a stand-in for quality of care in the United States, both with federal and insurance companies. And so it really gets to the point where as a practicing physician who's dealing with these guidelines, I have Medicare asking me literally patient by patient, did this patient get a mammogram? If they did not, I'm a bad doctor. My ACO loses money.
I know. Yeah.
This is a situation where it's like having people in the 19th century grade the quality of doctors by how many dropsy patients they phlebotomized.
Right. That's very good. Yeah.
So, what's your solution to that?
Yeah. Well, to stand up and say we're not taking this anymore. And let me just say what's happened here. The desire to measure quality is understandable. What's unacceptable is anything that goes under the name of a quality metric reliably measures quality, and we need to be accountable for something. There's no question about that. But we need to work on metrics that we think are genuinely important for our patients. What's happened is the screening metrics are brain dead easy to measure. It's just what proportion of your patient population have you done this, and this to, even though that may not represent good care, even though it may lead you to coerce people into things they don't want, which is terrible care. And we need to come back to the central things that I think is important about medicine, which is care for the people who are sick and injured, and how well we connect with them, and how well we communicate with them, and to what extent we actually care for them and stick with them. And we need to work on that kind of quality metric and move beyond what I agree with you are totally unimportant and, in fact, have very pernicious side effects that lead us to do things and distract us from other things that are more important.
Well, Dr. Welch, by mistake,
You're back.
I am. But by mistake, you were given an extra 15 minutes. And
my God.
And I've got 6 minutes.
Okay. All right, I'm sitting down.
Sit down. Because you and I have been friends a long time, and I know that I can ask you questions, and you'll take them in a friendly manner.
I think my prostate is at risk here.
Well, we can get into that. I do want to get into that. I want to get into the discussion.
We've got to even it up, don't we? We talked about breast enough. Let's talk about prostate.
No, we do. And I want to get onto that next. But one of the things that you said, which I really hope the audience heard, was there is a real important place for doctors. You can establish a relationship with doctors in two ways. One is you can get sick, which is what Dr. Welch said, and you can come and ask the doctor for help. In that case, the evidence supporting the treatment doesn't have to be great because you ask for it. The other way you can establish a relationship is you can be working in your garden, playing with your kids and grandkids, and somebody can come and knock on your door and say, you need to have your breasts examined. You need to have your prostate checked. That's what screening is about, and the level of evidence of benefit has to be unquestionable. Do you agree?
Totally.
Okay. So you understand we're talking about two different things.
100%. What he's saying, and I write about this in the book, our standards of evidence for intervening on well people who have no idea, there's no way for them to make any judgment about how good the intervention is. So our standards of intervening on the well population have to be at the absolute highest. We've got to really know what we're doing. Because again, it's hard to make well people feel better. It isn't that hard to mess them up. And some of you will remember the hormone replacement. For 10 years, we were doing the wrong thing for most women. And we've got to have a really high standard of evidence before we intervene. While the sick people, they can make their own judgments whether we're helping or not. Yes, sir.
Okay, your program is at the finding, the diagnosis. So let's tie it in with this program. Give us in 2 or 3 minutes the preventative diet for breast cancer.
I can't do that. I'll let Dr. McDougall. That's not outside of my area.
Okay.
I got enough problems following all those dots and lines. Come on.
Okay.
And dealing with the mammographers.
Well, I of course, in terms of your question, I didn't invite you to talk about diet. I invite you to, as you've done very well, to try and help my patients understand the limitations of screening. Which brings us to your prostate.
I'm tempted to bend over.
Dr. Welch, as men, you and I, and the rest of the medical male-based community, we've been ready to accept the fact that PSA tests are not a good thing. And most doctors realize, and most patients do, that PSA testing does far more harm than good. And would you say that's the standard? People believe that?
I don't know if it's the standard, but it's certainly widely. Yeah. I think in prostate cancer, the two sides of screening are best understood by the general.
Well, the U.S. Preventive Services Task Force says don't get it.
I think more and more people understand the two sides, and I guess the one thing I want to be clear is there's nothing special about prostate. These are general problems with screening. That whenever you have a strategy of looking for early forms of disease, you're going to find some that are never going to matter to patients, and that means you're going to be intervening on some unnecessarily. And you just have to understand that's a side effect.
Okay, my question.
Yes.
Analogous, prostate and the breast are analogous organs.
In some ways.
In many ways. In terms of embryologic development, in terms of cause of disease, natural history disease, results and outcome. Could you talk for just a minute about the male-dominated medical business and its effect in terms of gender bias? Just for a minute in terms of mammography, breast self-examination, and why don't we do prostate self-examination, and why have men went out okay and women are still being treated differently? Would you talk about that?
Should I talk about that for a minute?
Would you talk about that?
And he's throwing these flies, and I'm supposed to rise to it.
Last question.
Yeah, I appreciate the question. I won't take it, though.
All right.
Thank you very much.
Thank you
I'll see you in a
very
minute.
much. We're going to take a 15-minute break.